Okay, good morning, everyone. Get ready to today's medical meeting, medical infrared advance. And first of all, thank you for joining us in this exciting new meeting, our first medical webinar, 2024. So here we will explore some fascinating and advanced topics in medical infrared imaging. And I'm very glad that most people are registered to see this event. And some of you are seeing what we are doing at the American Academy of Thermology. So every Saturday, we are having the medical minutes, and today, the medical webinar 2024, with some friends, some speakers to share their acknowledgement with you, and you to share your questions and your experience with us. Perfect. Okay. My name is Marcus Brioski. I'm medical doctor and chairman of the American Academy of Thermology. And today I'm going to share a secret with you, another secret. Many of you have seen some of my presentations at the AT conference, and some of you may have wondered, oh, how does he create such amazing images? Well, today I'm going to review my secrets. So make sure to stay until the end of this presentation. Here's the first secret. I don't do thermography. Wow. You don't do? How is possible? Yes, we are doing infrared imaging. So I'm reinforce this concept again for everyone because it's very important to understand some little aspects of this. And the image you've seen me present are infrared image, but wait, they are the same thing, thermography and infrared imaging? Let's see this concept again. Recently, the AT updated its logo with Stephanie help. Thank you so much, Stephanie, for the new logo. And with a new subtitle, Medical Infrared Imaging. So it's very important, this changing. But why? Today, today's challenge is to explore the evolution of thermography and infrared imaging, particularly in how it has transformed clinical practice with AI driving. I'll speak at the end about AI, and especially the point of care approaches in vascular health, neuromodulation, and oncology. Oncology means not only breast, but other tumors too. And we'll be discussing the key differences between thermology, thermography, infrared imaging, and most importantly, why these distinctions matter for real-time diagnostics and treatments. Let's dive in and explore what has changed and how choosing the right terminology reflects the advancements we see in clinical practice and research today. Today, we are diving into how medical thermography and infrared imaging have evolved, particularly in the introduction of AI-driven point-of-care approaches. These advances are reshaping clinical practice in areas like vascular health, neuromodulation, oncology, as I told. Let's explore what has changed and how these new methods improve diagnosis accuracy and treatment. Thermography is a technique that captures infrared radiation to create thermal images, visually represent temperature variations on surface of objects or the human body, human skin. Infrared imaging, on the other hand, use specialized cameras, sensors, transducers to detect and visualize infrared radiation, heat, converting it into images that show temperature difference. While thermography focuses especially on measuring and recording surface temperature variations, infrared imaging is a broader concept. It involves capturing heat emitted by objects, whether or not it's used for temperature measurements. In 1956, the term medical thermography emerged from this man, Dr. Ray Lawson, from McGill University in Montreal, Canada, a former member of Royal Canadian Air Force in the Second World War, adapted military infrared technology developed during the Cold War for medical use. He was the first to make thermal observations of human metabolism, and Lawson discovered that breast tumors generate heat, with malignant nodules being 1.75 to 3.5 degrees hotter than surround tissue. At that time, in 1956, this breakthrough suggested that breast cancer could be detected by measuring heat, offering a non-invasive, very interesting alternative to the often inaccurate surgical biopsy. On that time, his work transformed this military tool into a revolutionary medical imaging technology. But he didn't have idea in what will happen, or he didn't have idea that today, October 19, we'll be here discussing about his discoveries and the new things that happen after this. His work transformed the medical approach, and which had the potential to change the way breast cancer was detected in women. But there's some very specific points to consider, and one is that it's not the same as mammography. You see this on our next presentation when Professor Rita will explain this point. But let's go ahead. In the year is 1933 in France, 23 years before Lawson work and before the Second War. Jean Seidman, a Romanian-born French physician, presented his doctoral thesis on medical treatment using ultraviolet, infrared radiation, X-ray, radio waves, as a proponent of actinotherapy, the treatment with radiation, especially ultraviolet rays, on that time. And Seidman was the first doctor to use infrared for diagnosis. We have evidence of this in publications from the reports of the Paris Academy of Science from that time. Let me share a quick excerpt from Jean Seidman 1933 publication titled Radiation on the Technique of Measuring the Thermal Radiation of the Skin. He described a bedside, a point of care device for measuring skin radiation using an electric thermometer or bolometer. It could provide the skin temperature in just 10 seconds on that time using infrared technology. That's right, point of care infrared, all the way back in 1933. Why Seidman introduced thermography in 1933, it wasn't until 1956 that Lawson used it for diagnosing breast cancer. So it's not just 6 and 8 years of thermography. It's actually over 90 years of medical infrared science. In 1933, Jean Seidman conducted one of the first studies on the effect of physical work on body radiation. So it's the first sport infrared study in 1933. Their finds show that radiation barely changes even during intense exercise. They tested athletes, an obese person, and someone with Graves' disease, and found only a 3 to 5% variation in the radiation metabolism. This was a pioneering step in using infrared radiation to study the body during exercise. Sorry. Oops. Okay. Traditionally, thermography involved capturing thermal images for post-analysis. While useful, this method was limited because it lacked real-time feedback. It worked well for detecting superficial issues like temperature difference, but wasn't fully integrated in ongoing patient care until recently. So this is very important. The integration with the real life, the physician real life, the doctor real life, is to practice the medicine in front of his patient. Here we have classic thermography. In this method, we can use different color scales during post-processing to highlight specific structures of the body, like the eyes, the nose, lips, or temporal region. We can also apply image filters to focus on different systems. So if we change the color, we can give more highlight for muscular, vascular, inflammatory, metabolic, or nervous with specific softwares we developed for medical applications and other ones. And especially, we can use graphical methods to track the progression of diseases, tracking techniques, monitor treatment effectiveness, and assess patient recovery and prognosis. This means we are not just rely on subjective color evaluations, but also on quantitative measurements. This makes the method more precise and scientific, helping doctors make informed decisions, such as when to start antibiotics, recommend surgery, or change therapeutic approaches with the support of infrared images. Not only based on this, but it can give us the right way or make us to think about the better approach. In recent years, I developed with my team, 3D thermography system for mapping heat distribution. This system allows me to see details that aren't visible in 2D, two-dimensional. The depth effect gives me a much richer and more reliable view for thermographic evaluation. Here's an example of active herniated disc and lumbar discopathy, a functional image of this. Here's another example of 3D thermography for heat distribution mapping. Notice how clear this case of ankylosing spondylitis is. Even thought the MRI wasn't conclusive. And here is very easy to identify this and sure to correlate with the clinic and other exams. The 3D view with interferometry technique is truly remarkable. With classic thermography and post-processing, we reached the point where we can create incredible 3D images like this one, showing the intensity of radiation emitted by the brain, and even calculating brain metabolism in real time. This is useful for evaluation emotional states in diagnosed psychiatric conditions, such as depression, anxiety, aggression, schizophrenia, as well as Parkinson's, Alzheimer's disease, and some post-traumatic problems. To give support and measurement. Infrared imaging is evolution of thermography. Today, with real-time analysis and AI integration that we'll show at the end, we are able to make immediate decisions at the point of care. At the point of care. This is the point. This is crucial for fields like vascular medicine, neuromodulation, where quick insights into blood flow and nerve activity can drastically impact patient outcomes. 10 years ago, we moved away from using cameras on fixed towers and tripods and began using high-resolution portable cameras. This allowed us to get closer to patients, bedside, point of care, especially those with mobility uses, severe pain, and those in hospital outpatient units. So many of the speakers today will show their experience. Luciani will explain about her experience in thermography, and Rita in oncology, Sergio on healing. So you see most of the image they will show us are bedside or point of care, maybe in hospital or in their clinics, by using this approach that we are using 10 years ago. 5 years ago, we started using smaller, lighter portable cameras. Technology give this opportunity for us to use this device, the different kinds of device. Although they have lower resolution, they offer a special feature, the ability to fuse thermal invisible images, creating what we call multimodal or hybrid thermal visual images. This was a revolution. It gave doctors the freedom to use thermography in any setting. And veterinarians quickly embraced the portability as well. And now I can see the uses, my patients face up, close, and examine them at the same time. So I can have the camera in one hand and touch the patient with the other hand very close to him, because the lens of this equipment is different from the lens of the big ones. So everything is very close, and the doctors become more close to the patients, understand better what they are feeling on that moment. So this is infrared imaging. That's a little different from thermography. I can now capture fantastic images in real time, analyze them immediately, like in this case of fibromyalgia, where there's a significant noradrenergic vasomotor hyperactivity in the cold hands. Sure, I can take some pictures, I can touch on the patient, I can complement with some questions that I didn't make before, and I can do procedures all in real time, close to the patient. I can get a sense of brain metabolic activity through a thermobiological window located at the inner corner of the eyes. This connection between the brain and the exterior is called brain tunnel temperature. That's a concept that we are using 15 years since it was discovered and studied by Professor Mark Abreu from Yale University. He's a Brazilian, but he lives at the US and studied this very close. With this, we can measure metabolism and detect conditions like hypothyroidism. Real-time infrared imaging has allowed us to make incredible connections during physical exams. This patient, for example, who has sleep disorders, shows significant eyelid congestion that isn't visible to the naked eye. We can even relate the pain from temporomandibular dysfunction to insomnia through imaging. This is truly incredible, do in real time. For over 10 years, we have been performing infrared guided treatments, such as needling, acupuncture, shockwave therapy, laser therapy, neuromodulation. All of this is monitored in real time both by the doctor and the patient. The patient see the image on the screen during the procedure. This is very, very important because the patient becomes more close to the treatment. With this technology, we know exactly where we are applying the treatment and how it is affecting the patient at that moment. Today, many places still perform these procedures blindly, without fully understanding what is happening with the patient's body. Many friends of us doing blindly. Doctors and patients have to wait weeks to see if the treatment is working or not working and these things. Doctors use infrared guided therapy, know the immediate effects of treatment, real time. This leads to great patient satisfaction and faster recovery and patient involvement with the treatment. So it's not passive, it's active, and we work with the brain of the patient. During the pandemic, robotics emerged, specifically telerounding, where I started using robots to visit post-operative patients and evaluate their surgical scars and other biologic things from my home, without the risk of being exposed to COVID on that time. It was a time of great learning, but sad for other aspect, but for science, we have a great learning. And telemedicine and telerobotics with infrared are growing rapidly. It's not stopped. This was only possible with point-of-care infrared imaging. We no longer talk about thermography, but radar, infrared imaging, and more recently, it's becoming AI-assisted. In vascular health, almost in the finish, AI-assisted infrared imaging helps us quickly detect vascular dysfunction or venous stasis in real time without waiting for delayed analysis. This gives us the ability to identify issues early, improve intervention time and outcomes for patients. Here's a case of varicose veins. There's nothing visible to human eye, but with infrared imaging, nothing is impossible. The turtle's veins with slow blood flow and venous stasis become clear, very clear. These are invisible varicose veins causing discomfort for the patient. This is the point of care evaluation. Let me show. Okay, the next one. Oh, sorry. Here, this is another example of varicose veins that are not visible to human eye. However, in infrared image, we can detect irregular veins, areas slowed blood flow. This is why the correct term is infrared image, and it goes beyond the traditional thermography. We see, we palpate, we understand, we prescribe using infrared image. In neuromodulation, infrared imaging allows us to observe neuroactivity and temperature shifts related to pain or nerve dysfunction. This is real-time feedback is essential for adjusting treatment strategies, providing more precise and tailored patient care. In the 90s, at the age of medical thermography, Dr. Sumio Uematsu, he was past president of AAT on that times, and a neurosurgeon at Johns Hopkins, pioneered the concept of pain thermal mapping based on dermatomes or termatomes when they are seen in infrared. He introduced the idea of using thermography to measure temperature as a key tool for identifying abnormal areas according to his reference table and normal temperature range. So this will be explored by Luciane on her next presentation. Dr. Uematsu is recognized as the true pioneer in medical thermography. Since Lawson discovered, it's been 68 years and advancement in this field. But wait, something else has happened and we can't overlook it. In classical out in thermography, the most common method of measuring temperature differences between opposite sites. You select a region of interest, compare for the opposite, and subtract the average temperature difference. This is called calculating the delta to record the variation between two values. But this is very basic. It's just a subtraction. There's no statistical analysis involved. But it's important, but we can do much more, actually. Here's a current example of out-in concept in thermography. In a study I published on migraine, we collect images and then analyze the temperature distribution data later on a computer using statistical software. Although the images were taken at the bedside, the evaluation was done afterward, not in real time. But there is an example of infrared imaging, point of care real-time evaluation. Let me share some of my previous experience from the Spalding Neuromodulation Lab at Harvard Med School, Boston, Massachusetts, where I take part of this moment under Professor Philip Fragni coordination. One key observation we made was vasodilatation of the hands in response to TDCS, transcranial direct current stimulation. And this response shows how neuromodulation can affect blood flow, which is critical to understand how different areas of the body react to this type of stimulation, brain stimulation. We also compare this find with other neuromodulation methods using transcranial, intracranial, spinal electrical stimulation, highlighting how each method produces different effects on the body. These insights are crucial for advancing neuromodulation techniques and understanding their application in both research and clinical settings. In oncology, infrared is becoming a powerful tool for detecting tumor activity and monitor treatment effectiveness by visualizing metabolic changes as a biomarker and blood flow. We can get a non-invasive look at how tumors are behaving near the 0 point when they start into the development of palpable tumors. Offer another layer of insight for personalized cancer treatments. Many out-in thermography studies are conducted this way today. Thermal images are collected, the data is analyzed in tables, and using quantitative criteria, a result and diagnostic conclusion are generated. Numerous breast studies have been conducted following this exact process. Let's clarify the conceptual difference between thermography and infrared. So, in out-in concept, thermal data is collected from outside. In contrast, the in-out concept infrared image allows us directly visualize the heat distribution of the surface. So in thermography, we often use temperature color scales. On the right side of the thermal image, each color represents temperature, red for the hot, blue for the colder, green intermediate regions. This RGB system is easier to identify regions of higher metabolic activity. However, it's a 2D bidimensional image. With infrared image in out, I can get much more information in real time, immersing myself in a live recording or image. Moving the sensor close to the patient allows me to extract far more clinical details and make faster, more accurate diagnosis and treatments. Let's go. The most amazing thing, in my opinion, about infrared image is that it's not just for the doctor. It's also for the patient. Medical thermography doesn't make sense for the patient because most of the time they don't understand what's happened. But infrared imaging does. the patient becomes an active participant of diagnosis and treatment, watching in real time as something like a acupuncture needle affects their skin, for example. Together, the doctor and patient immerse themselves in a health issue, seeing what happens in the moment. You can even record an image for later analysis, just like thermography. But remember, thermography is the past. It's just a record. Infrared imaging is the present, an action to see what's happening right now. So here's the real time. Again, view a patient with a left shoulder pain. It's instant. The myofascial trigger point in the left here, confirm the initial diagnosis. Both the doctor and patient can follow along in real time. The doctor can quickly palpate, examine other areas guided by infrared technology. It's easier than medical ultrasound, faster and safer, but it's done in the beginning. This is the true medical evaluation. This is infrared image in action. To finish, I show you Illumi. Illumi is the artificial intelligence that will help us to learn more about infrared image, to help us to understand the images and increase our approach. For example, you see that you can capture the image, and at the same time, I choose here, let's see, foot care. What's foot care? Oh my God, here I open. Is recorded, but I can choose foot care. I will choose some image from the foot. As you can see here, here's only one image, and I put just analysis in English. Could be analysis, you can say the age of patient, the name, etc. And the system will recognize what is happening here. Will describe you in real time, in 2 or 3 seconds, what's happened. Measure the temperature, the distribution, to say if it is a risk of ulcer or neuropathy or peripheral artery disease. This system is based in 1 million images from my data bank. It's not open. It's a closed, it's a specific access for this, and it's based on neuronal network. Let's see the knee evaluation. This knee evaluation is to evaluate just the knee, so it's most common use in orthopedics. I choose one image from knee. The system will identify if it's the right or the left knee to identify what is happening there. So the system, based on what I learned to the system, you identify the structures, give the report in real time, save the distribution of that. But you must sure to review to see if it's okay. If you want to give more information on that. It's possible to have therapeutic recommendations if you want, like medications. Sure, you must to confirm it's not to be used alone, but must be reviewed with a doctor. So anti-inflammatory, antibiotics. And the last one, the breast evaluation, totally automatically. Here, where's my, here, okay. Almost there, sorry to extend so much. The breast, most complicated situation, but there's solution for that. All in English here. You choose the image. You can choose many images, lateral, oblique. So if you put more image, eat more. You can put the information of your patients, the name and the name of physician, the data, these things. This will appear on the screen. Here, the name of patient, the description of the problem, the grade of the problem, reference, and this is almost ready to be printed as a report. We must review and to confirm what's happened with the patient. And it's finished, just this. So this is the point of care AI driving technology present for the first time to AAT. Let me show the last. It is amazing. So let's go to the, sorry. sorry. Almost there. So medical infrared imaging covers a broader view. The literature is showing that if you're looking for infrared image, you have much more results. If you look in the all the papers in literature, you find much more, 4 times more than if you're looking for thermography. And if you're specifically medical, you also have this find much more medical infrared imaging than medical thermography. And this change in terminology can significantly impact how healthcare professional provides and utilize this tool. And here we have a challenge. How do you see the future of infrared imaging, medical imaging? Should it involve the name or preserve our roots? Sure, we can use the both, but we must understand. If Hippocrates were watching our discussion today, he'd be probably be laughing. 2,050 years ago, Hippocrates, the father of medicine, detect diseases, covering the patients with medicine where it dried faster, and he wrote, in whatever part of the body excess of heat or cold is felt, disease is there to be discovered. So we are doing the same as Hippocrates did 1,500 years ago, but actually with technology. Conclusion, infrared imaging has transformed the way we use thermography from real-time diagnostics to AI-enhanced accuracy. These advancements allow us to integrate imaging into point-of-care practice across multiple fields. This isn't just a technical upgrade, it's a shift in how we approach diagnosis and treatment planning, especially in high-impact areas like vascular health, neuromodulation, and quality. Thanks so much, and we are open for questions. Thank you.
Yeah, just a quick question on with point-of-care applications, you know, the obvious advantage is you're real time, you're closer. There's a lot of benefit here. But my question becomes with traditional imaging, we've always done acclimations, laboratory controls, and things like that. And would we be losing any data because we don't have those controls? And if so, would there be a role for both systems, meaning for certain analysis, you'd want all the controls, and for other types of analysis, you may be able to relax some of those controls and take advantage of the point of care flexibility?
Great question. We made this between us many times with our group, and the answer is you have 2 ways to do. So it's you must to compare as the ultrasound. Nowadays we have pocket ultrasound that many doctors do, obstetrics, vascular. They do very fast. It's just and they make a simple question. There's a problem here or not? Occlusion or not occlusion? Inflammation or not inflammation? Okay. But when the image are done in a lab, ultrasound lab, with a specialist, he will spend more time doing the same exam, and he will give more information about what's happened. What this means? Point of care, it's not good to do reports, for example. Because point of care is just I have a problem here. It's true that the patient have a pain here, or something very short question. Sometimes Kane, it's not possible to answer. Oh, no, it's very hot here. The patient's not prepared. Then you forget, not work on that moment. But not means that will not work all the moments. Most of time it works. So I can have idea that I have a problem on that moment, and can I change my treatment? But sure, we must to take care. We must to study. So we need to learn. We need to do courses. We need to wait. It's better to wait 20 minutes. It's better to do in a 23 Celsius degrees. These things is the basic. Is basic, but it's not. We cannot stop person to do point of care. They must understand. Oh, this image is a point of care or is a thermography? No, it's a thermography, traditional one. Oh, okay, great. And now I'm studying, comparing some drugs, doing point of care. Oh, it's not good because there are many problems on this. But you can use, but to compare drugs, if drug B or A is better, more complicated.
Yeah, so it's really about different applications. When certain applications are better suited to point of care, certain applications are better suited to fixed units with the standardized laboratory conditions. Now, that makes a lot of sense. I appreciate you clarifying that for me.
Yes, and I believe in future we have an UCI, intensive cares, with some cameras doing this in real time. Some basic things with beds on or the patient room or something like that. But sure, we must know the limits. Who will know the limits? The people that are studying infrared imaging, so they understanding what the limits, what's it's good or what is not good. So we must know how to interpret this, and we must to teach the others how to use this in the right way. So, but the point is, we don't have only one way to do all the things. We can spread more, a little more, and just give us liberty to do this, more freedom. And this freedom came with, we validated many aspects of this during our practice. And we want to share this on the courses, and we are open for many of you to take part of the course that we explain at the end of this meeting today. In very close time, and she has a lot of experience. She's one of the most person that understand neurothermography. So the next presentation, it will be about infrared neurovision. Luciane Balbino, she's from Brazil, is a physical medicine and rehabilitation specialist, and neurophysiologist, and also thermologist with us. Thank you, Luciane, to come and to accept the invitation to take part with us.
Thank you so much, Marcos, and good morning to everyone. I will share my presentation. Let's try this. It's okay?
Yes.
Can you see in a big image? Yes. Okay, and thank you for the invitation. I will talk a little about infrared imaging applied to neurological conditions, about my experience as a neurophysiologist using infrared imaging together with another methods of analysis as EMG and nerve ultrasound, something like that, and in clinical presentation of the patients. And I have been dedicated for many years in research and clinical practice using infrared functional image, because infrared is a functional image, is a great advantage when we compare with another methods. Here, for example, we have two images from a paper about Parkinson's disease, and we can talk about Parkinson's disease as a principal motor symptoms in the first time, but it isn't. It isn't, because in this image A, for example, we have a control subject without Parkinson's disease or another neurological conditions after a cold stress test. Is a provocative test for sympathetic nervous system. And in B, we have a Parkinson's disease in a very early part of this disease after a cold stress test. And you can see the asymmetry. You can see in the left hand with a very asymmetry from the right hand. If you can measure this, but we can see like this only by the colors of the color scale used in this image. So we can talk about Parkinson's disease as a model, as an example for applying infrared image in neurological conditions. Because the autonomic dysfunction in neurological conditions precede the motor symptoms. So it's an example. Because thermoregulation is altered by central or peripheral autonomic involvement in Parkinson's disease and another disease like small fibers neuropathy, for example. We'll talk about this in a little moment, in a few minutes. Sorry, because my voice is not so good. And this alteration of skin vasomotor reflex can be measured by flow meter, for example, but it's very expensive and very difficult to do. You can do this by infrared image in a very easy way, very quick way, and cheaper. And it's very interesting to do this in real time. I will talk about this. In cervical and lumbar radiculopathies, we can see very clearly, even without measure the thermal difference in between the segments. For example, we can see the different colors in a color scale like this. And what happens with the segment when we have a radiculopathy? We have a reflex, and you can see this in infrared image because we have changes in thermoregulation. You can see this in the skin with infrared image. We have a hyporadiation. It means hypothermia in this segment because we have a sympathetic reflex in a distance when we have a compression by a discal hernia, for example, or another kind of disease at spine. You can see this in lumbar and in cervical. It's very in a very easy and quick way during your examination, in the same time with your physical examination at your clinic. You can see the difference between peripheral neurological conditions and central conditions. Here we can see in this paper the images in a patient in three different moments. Day 2 of a central condition, and we have a very clear asymmetry in hands and feet, for example, because we have a very sympathetic manifestation. And 30 days after, we have a moderate asymmetry. And 6 months, when the patients there is in a controlled situation of this disease, this is a kind of complicated migraine. You have a normal image. You can see in a very acute situation the asymmetry between the segments, and you can measure this and monitor this in a month or 6 months like this. So we can see in a real time, for example, in an emergency room, if this patient have a condition, peripheral condition or a central condition. Is very different in treatment, in acute treatment. So it's very important to know this, take this in mind. In this situation, for example, how can I differentiate in headache situations about migraine and tension headache, for example, in a crisis? It could be difficult to know the difference without infrared image. If I have infrared image, I can see if this patient have the regular temperature and face a face symmetric about temperature, and I can see on the right here the map of trigger points. There are a lot of trigger points doing the same symptoms in a headache crisis. So, for example, I can see the difference, and I can get the best treatment for this patient just using infrared imaging in a first instance before another investigation. In peripheral neuropathy, for example, in this case, is a patient of mine. He came for EMG, and he was very symptomatic for median nerve compression, like a carpal tunnel syndrome. You can see in this image, in a gradient scale, you can see this is broken. The gradient here in the median area, sensitive median area, you can see the difference, and you can measure the difference between a median area in the skin and the ulnar cubital area in the skin. And you have this in a very quick way, you can see this patient have carpal tunnel syndrome in very early development, and the EMG is a normal at this time. It's very usual in our clinic, so you have to do this in mind. It's very interesting to use infrared imaging for peripheral neuropathy, especially in compressive ones. When I have neuropathic pain, for example, in this case, a complex regional pain syndrome, sometimes it's difficult to know about the confirm the diagnosis. You can use infrared thermography using cold stress test for improve the sensitivity of this test. Here we have in our clinic, for example, we can use this cold stress test in a non-symptomatic segment as feet, for example, and we can monitor the hands at the same time. We can see the physiologic response. When we cooler segment, we have a cooler in another segment. It's a physiologic normal response. When we have a paradoxal increase of temperature, for example, in the symptomatic segment, we know we have a dysfunction sympathetic activity, and you can prove this by infrared imaging, and we can see this patient in evaluation time in 1 month and 2 months and 3 months. We can have our protocol for this. For example, we use this before treatment in complex pain syndromes. We can use video, or you can take seriate photos in each minute, about 5 or 10 minutes at in a complete test. Also, so it's very quick to do this. Here we have Marcos Brioski image about a spinal cord injury in real time in car crash, for example. We can see if you have a spinal cord injury and take care of this part of spine, for example, cervical or lumbar. We can see a massive vasodilatation occurring below the level of the lesion. And we have 2 side body loss thermal control in a very acute time, because we have quickly decreased level of sympathetic activity. So we don't have the normal sympathetic reflex. We have a vasodilatation with very quick increase of temperature in the segment. So we can see this is very useful for acute time at the emergency room for neurologic conditions like spinal cord injury, for example. In diabetic peripheral neuropathy, we have a lot of papers. If you research at PubMed, for example, we have a lot of papers about this kind of research. It's a valuable tool in the early diagnosis and monitoring of diabetic peripheral neuropathy, because it's non-invasive, is a convenient method to detect temperature variations associated with neuropathic changes. In how can I say, early diagnosis is important because we have EMG diagnosis only when we have more not small fibers compromised. And early in diabetic neuropathy, we have small fibers compromised because we have like heat feet at night, for example, and the EMG will be a very normal test in this part of the disease. So thermography, infrared imaging, can complement this by providing additional information on subclinical changes and thermoregulatory impairments. Here we have two images. It's about a paper. This is free. If you free paper, if you look for this at PubMed. In the A, we have small fibers neuropathy is very early diagnosis. The patient have a EMG normal at this time. And in image B, we have a patient control subject without small fiber neuropathy. It's very different. We have in A chaos, not thermoregulatory function. We have a dysfunction. We have a vasomotor dysfunction because the C fibers, the vasomotor C fibers are dysfunctional. Yeah, so we can see in a very easy way about only looking at the difference of temperature and color in this image. We have the interdigital anisothermal demonstrated in more than 80% of sensitivity. So it's very quick for diagnosing diabetic neuropathy in a very early signs of this dysfunction, neuropathic dysfunction. In real life, what can we see? This, in our clinic, we have the infrared image put on all the time. The patient came to the office and without clothes in the region of interest, of course. And we have the screen for patient observation. It's very important for the patient to look at this at the same time in real time, because it's more comfortable for this person to see the image at the same time as the doctor. Here we have no so good quality image. Is a patient with brachial plexus lesion, motorcycle accident, very, very usual in our country, because we have a lot of young people doing this as a professional. We call motoboy. It's a transportation of things and food and something like that. A lot of people driving in a crazy way, and a lot of accidents with motorcycle. So we generally use infrared image before EMG. For this case, you can see the hyporadiation is cooler in the whole arm, left arm, when you compare with the right arm. So it's very easy to see. We can use this in a EMG lab with children because it's comfortable. You use infrared image before perform the EMG tests with needle and electroshock. Here is another application, very important for us to see this patient in different times in a treatment. we can monitor the efficacy of this treatment. Here we have a male, 74 years old, pre-diabetic. It's important to say, in our research, we see more neuropathy in pre-diabetic subjects when we compare with diabetic subjects. Why this happens? Because this pre-diabetic subject, this person doesn't have any treatment for this glycemia. This person doesn't have any treatment, any control, any medical appointment. When this person is a real diabetic patient, so this person received the correct treatment, but the neuropathy, diabetic neuropathy, is very early in this disease because it's very sensitive. The peripheral nerves are very sensitive to different glycemic measurements. So here we have the first appointment. We have this image is more chaotic in kinds of thermoregulatory situation. And 6 weeks after treatment, this person have a more regular thermal regulation. So we have improve in C fibers. You can see the thermal gradients more uniform here. It's very important to use this because this patient was thinking about, whoa, why I'm doing this treatment? I can't improve this function. So you can show the patient this improvement is very important for follow up, not only for the doctor, for the medical doctor, but for patient in instance. Thank you so much. I'm here for your questions.
Congratulations, very nice. We here react. Everybody can use the clap if you want. Hey, okay, go ahead, Jen. Open your microphone if you want to make a question.
Yes, Dr. Balbino. Hello.
Go ahead, Jean. Go ahead.
Hello. Yes, very nice presentation. Now, Dr. Uematsu, a long time ago, said that if you have a partial compression of a peripheral nerve, such as carpal tunnel syndrome or other entrapment syndromes, that actually increases the sympathetic tone and not decreases. Are you finding that?
Thank you for your question. Sometimes we have this, and sometimes we have cooler. It depends of the time of the development of the compression. Yes, sometimes if you have more sympathetic blockage, we have the increased temperature in the area of the peripheral nerve. But sometimes you have, how can I say, it's a personal observation, not published. So it depends of the time of the sympathetic dysfunction. The important thing is, if you have different appearance, gradient broken, there's a break in a gradient, thermal gradient, independence of it is cooler or heat. Yes, you only look at the difference in the sensitive area of this nerve. So you can see there is a neuropathy there. But your question is very important. If you have a very acute situation, you use is more used to see the heated in the sensitive area. But sometimes 1, 2, 3 months ago, after this, after the first symptoms, we have this image. But we have to do more research about this. It's a compromise for me. I will do this and I will show in another time. Okay? And thank you.
And please, Sergio, my friend Sergio, he's one of the most recent professors in thermography, and he's a friend of mine. And he made the specialization with us at São Paulo University, and he has amazing experience in so fast, in a short time, and he is a medical toxicologist. We focus on envenomation and healing. So he works with ulcers, snakes, bites, and have experience with other kind of intoxications and healing, and have a high experience in the use of infrared in intensive cares. So welcome, Sergio Machado from Uruguay, and also he is the president of Uruguay Thermology Association. Welcome to our meeting, Sergio.
Hi, morning, dears from Uruguay. I'm Sergio Machado. Thanks so much, Professor Marcos Brioski, Chairman for American Academy of Thermology. Stephanie, you can resolve our scenarios. Okay, let's go. This is the first presentation from the Uruguayan Association of Medical Thermology. I'm chairman. Here now stay the vice president, Dr. Professor Adrian Sosa from Uruguay. You listen me okay?
Okay, Sergio, it's very good.
Okay, perfect. Okay, the first, in Uruguay, we stay here. Long road away from thermology, but working together around the world, other countries, many other specialization from medical and other technologies. We share it to be today integration of infrared imaging technology with a study of healing and post-chirurgical monitoring, and the impact and accuracy, safety, and patients' outcomes after surgery. Include experience with children in pediatrics, intensive care, and rheumatology. Point-of-care applications of infrared imaging and snake and spiders and venomations, and then the follow-up. And me, the Professor Marcos Brioski presented me, but I am assistant academic units of toxicology and occupational health on University of Udelar in Uruguay, specialized in medical thermology by Auterm and Abraterm, professor from Uruguayan Association of Medical Thermology, full member of EET, Abraterm, and AET, president from Uruguayan, and researcher for three most important units in Uruguay: research in pediatric medical thermology, teen-child intensive care unity, and the enteroparenteral nutrition unit, the first hospital and the reference in Uruguay, and rheumatology service and the pediatric hospital, and the poison thermology team from the Academy Unity Toxicology and the Hospital of Clinics in Uruguay. Why is important thermology now in Uruguay? Our term search from last 2023 now confirmed from 25 medicals and nursings, yes, and inside learning thermology, all medicals formed from thermology level 2, in Bern, the thermology first team in Uruguay and the South America Research Pediatric Intensive Care Units, everything in point of care. These professors you see there in the pictures, Professor Andrea, Professor Juan Guerrero, and me, as the first national, making the first national protocol of thermology applying in point of care. Okay? All researchers prior 6-month training in level 2 thermology for outpatients. This is approved for Committee National Pediatrics Reference Hospital, and this leading team thermology in the pediatric level in Uruguay. Now we can up 10,000 thermal imaging in the point of care. Yes, first we need protocolizing the researching, and this is resume this one. We work to do in 2 rooms bedside. Yes, the first intermediate bedside, and here the intensive care bedside between different logistical from beds, and we need adapter the protocol for this one. For example, the patients inside strapped are 45 degrees. We need to remove these holders. We need repositioning the tube because interfering from the air, hot air and cold air in same time is too much important for this area. We need a control area from the thorax. Our image is working inside the unit bed. We need positional hand thermal camera for 30 centimeters from 1 meter, 30 centimeters for the smallest sensors, and for big sensors too much long. Everything unit is stay in 23 degrees because it's very important to not proliferating the bacterial in the inside area and virus. This is much good for thermology because it's a temperature similar to Glamorgan protocols, AET protocols, and inside Uruguay protocols. The maximum researchers inside the unity in every moment is a free, and 1 parents for this design unities. And pediatric intensive care unity for more thermology team working inside the room and the point of care, if you see back the pictures, and a setup unity to avoid bacterial proliferation. You can see about next before images, it's 22 degrees. The humidity from inside is 50, 10 or more, or 10 or down, maximum 4 people inside here. And the first most important, it's we are teaching with real-time infrared images from residents, graduated patients, and interns, all the moments. It's the first for inside the mind from next generation medicals, from integrated medical thermology inside here. Look at that. This is this one professor, and we researchers inside the room. Hers. We heard about picture from the residents and interns. See there other side outside from the unity. This is not our hospital pediatrics reference inside in Montevideo, Uruguay, where the research takes place. We take images inside the surgery rooms, inside bedside unities, inside intermediate bed units, and other sites consultings. We study post-chirurgical injuries, envenomation, bone fractures, wounds, and others. And we can almost clinical cases shared with you and look at that. This is the first clinical case. This is a child, the 10 and the 8 years. We were consulting about idiopathic pancreatitis after 10 years progress without fever and without focus. And then the question of pediatrics is possible thermology identify areas with interest, because remember, we teaching inside people, research, residents, interns, and postgraduate, and professors for pediatrics. In this moment, we got study these patients from the bed, yes, and see this area here and here. From the must be protocol, we utilize here area, control area without everything exposed from the air. And this point, the temperature is stable, very stable. You can use this one for control. Look at that, very interesting. Inside, in front abdomen, here, right, you will detect up temperatures here in R1 is too much bigger. Okay, nice. In this moment, the pediatrics call the echo sound physician, and the echo sound detects intra-abdominal fluid collection compatible with a described infrared imaging. We requiring aspiration, and it contains fluid residue with liquefaction of the pancreas. Here, thermology, imaging, infrared imaging. This is multispectral here. This thermal here, and this collection from pancreatics inside abdominal. Next case, 6-year-old patient will receive a horse kick at the level up upper jaw face. The team performed an infrared image where large inflammation was observed. Without areas is not possible necrosis, and we also location the delta T values compatible with fractures. And others authors described 0.9. This is the break point for the fractures in bones. And look at that, please. This stay here second day from the patient. Look at that here, the 5D tomography reconstruction. Here, front image, see the broken orbitary area, upside and maxillary. And this one, the reconstruction, left and right, the reconstruction ER 3D thermography image. Look at that inside, up areas of inflammation, and see the areas without delta T upside too much to 1.14. Here is average can use it. See that? The extrusion area of the bones on the skull, look at that, maxillar 2 times, zygomatic arc, and orbital area. And here, the point of the region of interest, you can see study in this area. Same image, we found the stacked area for a study on delta T encounters in neuroi. Same patients, same image. This is the next week. Down inflammation, very favorable, and won't have no major complications around the outcome. Look at that, down the average area, 1.101. This is a reconstruction 3D image, thermology. And this area study and the patients without, you can see outcome then. This is another case. It's very interesting. A 10-year-old boy playing in the park, and steps from the turn from a black acacia plant. Look at that. This is more poisoning. No, are frequently and much pain. This is area here. This is area from the bite. Okay, this is the plant. This one inside the room, and it is play soccer. It's no shoes. Here, this area inside. 8 days after the poison, this here the patient and the pediatrics from intensive care area ask about, it's possible thermography identify areas from the shoes for more interesting. Okay, the request access of an injury, we come inside the room and, oops, here, look at that. The first image of thermology, and we see then area for hyperradiant area, and is most called attention from this area. Okay, we observed an infrared imaging in area from inflammation that coincides the sector of the entry of the spine. It's here, no problem. Or why this one? But the college attention, the central hyperradiant ROI here. We immediately suggest echo sound for identify a possible compartment syndrome and confirmation this one, and require fasciotomy for emergency. This other point, this area, we study the wound, yes, from only one profile ROI, and here we see a 3D image from observed all regions, and here this is very cold area. Inside the room, this is hemorrhagic blood and compartmental syndrome very strongest. We need very different area for fasciotomy, and this patient in evolution outcome is good. And the protocol, the bird inside the pediatric hospital, we study behavior at central venous pathway palliative patients to prevent complications, and they require surgery to place or remove the pathway. Infrared images allow detection increases in deltas and the site and monitoring humoral markers for well starting antibiotics with values that exceed 2.2 Celsius ROI. It's reported from Co and et al. See the infrared image, we detect hyperradiant area from inside into the catheters, and as well, this patient need to remove them. These 3D reconstruct images from observed from the pediatrics understand area complementary from the ROI. This patient's evolution is outcomes favorable. Next case, 1 month surgery, severe intraventricular communications. Here's a beard. 48 hours, he's presented fever. After surgery, we monitored it for infrared images in point of care, and we observed very low temperature here. This is optics image, and the first in prison, it is okay. But here, the fever. we insisted this personal chirurgical technique for asking about why, hey, you removed the sternum or had to be stay here? The surgeons respond, yes, we removed part of the sternum. Okay, the culture perhaps pending and not result, and ultrasound in emergency in the intensive care area is not available from this moment. You applying a thermology and point of care. Look at that. We see area from the healing, and this area area is called from why here area. Look at that. We use the exposed area is a thermostable from intensive care units, and here is down temperature. Okay, the surgeons are finally realize echo sound and see possible complications from the sternum upside. Here, remove upside sternum reconstruction and remove chondroplastic area. Here, through the reconstruction. In here, second week about surgery. Look at that. The patient is more no inflammation area. It's more stable. The third reconstruction is very stable. In comparison to the first area upside post-chirurgicals. This patient evolution favorable in the next weeks. But we use not only thermology from static, we use the dynamic thermology. And look at that, this is the same patient, post-chirurgical, we identify difficult from insufficient respiratory because you don't sternum. The complacency of the thorax is modified. And this one, we can see the metabolic area from the diaphragmatic area. This is the first images, and the pediatrics is learned with us for other focus for treatments. This is other case, is very interesting. 1 month old infant from respiratory syncytial cell virus from respiratory failure. This assessed at the point of care, and we realize infrared imaging shows increase of metabolism and vascularization diaphragm area, but see the hypoxemia in hands. Sorry. Here. Look at that. See there, the hypoxemia area, and the professor Andrea, her right area, need intubation this patient from resolve the insufficient respiratory and resolve that is okay outcome. Now, we are the first national product scientific public paper in Uruguay. In next October and November, the 1st November, we need the first in Society Uruguayan Pediatrics, the first researching from thermology. The second protocol, now you bird inside the pediatrics hospital is rheumatherm protocol. with the Rodrigo Suarez, MD, Pediatrics Rheumatology. It's the first reference pediatrics rheumatology in Uruguay. And we approved for Ethics Committee from Ministerial of the Health in Uruguay. First phase for product protocols. And in Uruguay and the pediatrics hospital, we participate from scientific meetings or interclinical conferences with various pediatric specialists and discuss the case with pre-residents and postgraduates. It's the case for rheumatology, 80 years severe pain with functional impotence of knee and foot, subjective scale pain for 6 to 10 of the pain, and the infrared patterns of juvenile idiopathic arthritis. This is a protocol for studies for the next researcher team. On the left, you can see here, on the left, you can see 2 days after very strong pain. Here, this is area of their interest. And the right, after treatment from biologics, the patient descend the 6 to 10 to 3 for 10 subjective pain scale. Remember, no exists other technique if permit see the pain and extremely subjective and objective mediation about the delta T. Here is delta T average 1.57, and look at that 0.73 after treatment from biologicals for 4 days. This is other patient for required traction for a week to modify state for his muscles. Infrared imaging accurate data for assess of posterior lumbar thoracic muscle load. Here showing modified for patient load and being able to carry out normal life. Look at that, see the images. The first here, the patient is a very strongest and difficult from charge area for muscles. Here and here. It's after traction and surgery from the removing the cone. Look at that distribution of the metabolic areas and charge areas from the muscles. Here, from medication and preload and post-surgery, look at that distribution from the charger of lower and dorsal muscles preloading. This is the first team from poisonous animals thermographics in Uruguay, and Professor Alba Negrin and Professor Tortorella. We researchers of thermology poison animals for clinical hospital from the Center of Toxicology and National Center of Toxicology. We are going to cases for interest. Here is a 33-year-old male. Is a nursing, left hand made with an injury of dorsal on the first finger here on the left hand, presented with a blood blister from phalanx joints 2 days after bite. Okay, this is 12 days. Delta T values around the surrounding ischemic area. And look, in poisons and venomations, we need everything comparison asymmetries. This is difference from the wounds and healings. You can use it the same area for a study. Same area, peri area, and normal area, and the same leg and the same brains. But for poisonous animals, you can use it other side, because the leg on the hand, the total size is affected for venom. This area, delta T response, is a venom from Loxosceles laetra here in United States. Perhaps you can Loxosceles reclusa, you not laeta and not gaucho. And the action, physiopathology action is the sphingomyelase and hyaluronidase, by involving a mummification phenomenon and inflammation phenomenon. Here the inflammation, and here at the same time drug a possible necrosis. This 12 days after bite, the mummification area for the hand, and now this moment the surgery is applied to remove the hand. But the medical treating inside a sildenafil field for 8 days, and we kind reconstruction and repaired area, and now this one 3 months after bite, evolution, partial recovery, and mobility, and low sensitive inside abdominal skin graft here. Patient loses functional. Other types from functional. This is emergency nursing. Now, this is never area from emergency with the lost functional capacity from dominant hand, and we stay from residual dysesthesia, paresthesias, and now he performs administrative tasks in emergency rooms. This is a 49-year-old male consultant in intense pain here. Look at that here. This is the bite area on left hand. After 2 hours evolution, we worked at supermarket and worked hand after manipulating wooden banana box. This one is a phoneotronic inverter, the banana spider in Brazil, in tropical areas. The injury involved a left middle finger with edema here. Dysesthesia, intense pain, 10 for 10. We ask about in 10 for 10. But no required antidotes. Yes, the indication for antidotes, we need other clinical stage. The delta T observer area, inflammation area, and inside swelling. This is reported for Medeiros et al. And others and venomous from the scorpions, and same based same enzymes from phoneotronic inverter. But the thermography, it's not can use it only for bad evolution. Here is a patient from the dry bite. We ask about for Micrurus alterotis coral inside left hand here. And look at that. We see for rainbow high contrast, we can see a gradient distribution and no way modify. And look at that, the average 0.08. This is the dry bite. Come back home and see morning. No required antivenom. The Toxicological Information Device Center receives acquiring about cases of accidents by poison animals 24 hours a day, 365 days of the year. The snake botrops alternatus and pubescens found responsible in Uruguay for 60 cases annually. Its venom is capable for causing serious local alterations at the site at the bite, and envenomation independent from neutralization of envenom. This one reason from you can use thermal infrared images from follow up the cases of envenomations. Any cases, this is a patient from Discoprotastine, dwarf firms with a bite at the lower left wing. His descent of the horse, and the bite site is this area. Delicate, very delicate area. and lower left limb by botrops and receive serum for 4 days after bite. We can register the imaging 4 days after bite. Local phenomena persisted. Look at that. We neutralizing antidote system or patients no diet, but local phenomena are independent from neutralizing of antidotes. This patient evolution for 2 days after later, no complications. As a 5-year-old girl, consult first day after suffering snake bite while flying a kite. Look at that, flying a kite. Identify a botrops pubescens and the other inner surface on the right foot. Here, this here and here area, the bite. Yes? This receiving 8 vials of an antibiotic serum, and the system is resolved. But the local phenomena is very complicated from the next days. They presented asymmetries and severe thermal dysfunctions, tumor 1 delta T. Monteiro, it's reported this one in 2011. And this patient 1.8. 6 days after bite, look at that an area here is edema, inflammation, very strong at pain, and here area, look at that. 6 days, 7 days. Inside here, look at that, the average, 5.5. Remember, we don't comparison same area. We did comparison asymmetries because envenomation is complicated all legs. 60 days after bite, the patient's evolution is very favorable, and we comparison humoral markers, PCR, PCT, and deltas value for thermography detect change possible for complications 1 day after the values alterations humorals. And 67 days after bite, the patients recuperate all and no complications. See, will come back and return to fly a kite in the same side after bite 68 years ago. We use infrared images to help others to return back to their lives. Now, we can these pictures from symbols for Professor Sergio Machado, chairman for the American Uruguayan Thermology Association, Professor Adrian Sosa, and we, Marcus Brioski, chairman for AAT. See the Uruguay, this is a small country of the South America. And my favorite words is we must work together to bring infrared images to confines of medicine. And remember, with big science, there is no small countries. Thanks so much.
Very good, man. Congratulations. Let me clamp for your presentation. And it's very impressive. A small country, but with brilliant minds. Does anyone have questions here? And thank you to Adrian Souza. I know he most of this presentation, he is responsible of this. Thank you so much, Adrian. Congratulations for your work at Uruguay. It's an example for many countries at South America and other countries at the world. And you prove that how much is important infrared imaging and how it can really save lives beyond the breast cancer, but you have many other situations, infections, bites, and that we really can save limbs. So it's very important. And it's most of you here, you have a sensor, you have a camera, you can do similar things. Just practice, we need to show to the people we must to invite more people to take part of AAT, to know what we are doing, and sure we are here as in the name of American Academy to spread this to different fields of application. Okay. Does anyone have any question? Does anyone?
Just a comment.
Oh, please go ahead.
Dr. Picado, very nice showing of that very localized compartment syndrome in the foot. This is an important thing for the emergency departments around the world. There's a very good study out of Harvard just done with your little pocket IR cameras that really showed in calf compartment syndrome, the foot became extremely hypothermic despite having good pulses. If this is an easy way to pick up compartment syndrome, that would be a big breakthrough. Thank you for your comments on that.
Yes, very important you're approaching, Jean, because for the diagnostic of compartmental syndrome, we need inside compartment pressures. This is up for 30 millimeters and invasive area. Imagine, come on, this child, pain to pain, very strong pain, and we need a subside from and quantificate from intra compartment pressures is not possible.
Yeah, very good.
Thanks so much.
Thanks so much. I will have other questions at the end, so we'll do a round with all the speakers at the end. So stay until the end of this meeting. And now we go ahead. We go ahead with one of the most expected presentations. I know much of you, a lot of you love this theme about breast, and I invited a friend. She's a specialist in gynecologist. She's also a specialist in acupuncture, thermology. He finished his specialization on USP, São Paulo University with us. And she has a great experience with menopause. So when we're talking about the breasts, it's not only the cancer, but there are many benign but not so good situations for women. And it's very important we know beyond the cancer when you're talking about breast thermography. Welcome, Rita de Cássia, Dantas, Monteiro, Santana, from the northwest of Brazil, one amazing regions, very warm. I love to travel there because it's a beautiful place. Go ahead, Rita. Welcome. Thank you so much.
Good afternoon. I will share.
I help you, no problem.
Okay?
It's going. Okay, nice.
Okay.
Everything is okay.
I'm very grateful and proud to have been invited by AAT to share my experiences with this select group of professionals. Thank you so much. My topic is breast infrared vision, application during hormone treatment in menopause. Não está passando? Okay. Of this presentation, my objective is to relate the symptoms of menopause, the use of hormone therapy, and breast health, to understand the role of infrared imaging in detecting and monitor functional changes in breasts, and my approach during hormone therapy. The menopause sets in usually around the age of 50, with significant changes in a woman's life. The main symptoms are vasomotor, like hot flashes, heat waves, genitourinary symptoms, like vaginal dryness, changes in mood, sleep, and the onset of chronic diseases such as osteoporosis and sarcopenia. Hormone therapy is often needed to reduce symptoms and increase a woman's overall health. Hormone therapy, when indicated, we need to use hormone therapy following guidelines and use drugs endorsed by the main national and international societies with individualized treatment, assessing risks so that the benefits are safe. The main regimes are systemic estrogen, vaginal estrogen, and combined estrogen plus progesterone regime. In women with uterus for protection and prevention of endometrial cancer. Breast cancer and hormone therapy. Breast cancer is the most insidious and most frequent cause of cancer death in women worldwide. Although there is a lack of consensus on the subject, there are studies with a high level of evidence on the increased risk of breast cancer in HE users, especially in combined estrogen and progesterone regimes. Similar to this randomized trial from Women's Health Initiative in 2002, and this meta-analysis and systematic review of prospective epidemiological studies from collaborative group on hormone factors in breast cancer, published in the Lancet 2019. There are studies with high-level evidence, like those ones with change in hormone type to natural progesterone, which have already shown a reduction in the risk associated with breast cancer. But what do the guidelines of the menopause societies recommended? For symptomatic health women under the age of 60 or within 10 years in menopause, the positive effects of hormone therapy on coronary heart disease and all-cause mortality should be considered in relation to her potential increase in the risk of breast cancer. Individualized treatments while respecting contraindications, such as a personal history of breast cancer. Screen for breast cancer before and during HT with annual mammography start at age 40. In dense breasts, add ultrasound and MRI. Vaginal HT is safe, and combined hormone therapy, estrogen plus progesterone, increase breast density, make mammography more difficult to interpret, and increase the risk of later diagnosis. And we know how important early diagnosis is. As Dr. Brioski asserts, early diagnosis has no clinical signs. Current screening is limited by the size of the tumor, around 80 millimeters. Isolated examinations are generally not effective, especially in dense breasts. Infrared breast imaging can detect early changes before structural changes are visible on mammography. But infrared breast vision does not replace anatomical examinations such as mammography, nor does it replace current breast cancer screening. It can be used in conjunction with these tests and can provide valuable information in the functional assessment of breast health. This is a complex exam due to the polyformism and particularities of breasts, and should be carried out by a professional with the appropriate training to assess various possibilities of finds together with breast specialists. Infrared vision has limitations like any other assessment among them. The location of the thermal alteration and the anatomic alteration may be different. It does not detect nodules and does not guide biopsies. Specialized software can facilitate functional assessment in image analysis. The association with artificial intelligence, AI, is become more common. However, the accuracy of the results that depends on the training of algorithm from a consistent database like infrared med. The presence of a tumor, angiogenesis, inflammation, and endocrine changes modify the temperature by increasing metabolism and altering the vascularization of the breasts. These changes precede the anatomical ones, generate heat and heat to a visible pair of vessels and heated areas, hotspots, that can be detected and monitored through infrared image sequentially over time. A persistent alteration can be an early sign in 10 to 30% of breast tumor cases. Glossary. How I manage patients on hormone therapy. Hormone therapy increases breast metabolism. First, I request breast cancer screen test, such as mammography. In my country, it is recommended. After that, I capture infrared images of breasts according to Abraham protocol. Then I study the image with specialized software and send them for later assessment with the help of AI in infrared database with Dr. Brioski for risk classification according to findings of thermovascular asymmetry. The infrared imaging complements mammography by identifying breasts at risk before and during HT and monitors the progression of the risk over time with sequential images, which allow me to implement early interventions to make hormone treatment safer. I will now present some clinical cases and my approach according to thermovascular risk, Th1 and Th2 risk. A 65-year-old patient has been on hormone replacement therapy for 10 years. Mammography is classified as BI-RADS 2. I have been monitoring her with infrared imaging for 4 years, which show increased metabolism and vascularization typical of HRT. She has consistently remained at thermovascular risk level 2 over time, and I have continued the HRT. This case, Th3 risk, low suspicion with mild change, systemic HRT initiation, and active surveillance. This 59-year-old patient with a BI-RAD 3 mammography has been undergoing hormone replacement therapy for 5 years. After this period, she began to show significant changes in metabolism and vascularization after 5 years, with an 87% increase in the average temperature of the right breast over the past year. We discontinued systemic HRT, despite the thermovascular risk remaining at level 3. Systemic HRT was replaced with vaginal HRT. Her sister was diagnosed with breast cancer 3 months ago. T8 risk, moderate suspicion. In these cases, we use vaginal HT surveillance and share the patient with breast specialists. I am a gynecologist. This patient has also shown progressive changes in the right breast over time. She is 58 years old with a BI-RAD 3 mammography. She has been under infrared imaging monitoring for 4 years with a thermovascular risk level 4. She's not on HRT, yet the average temperature of the right breast has increased by 32% during this period. A star-shaped vessel is present in the right breast. T8-4 to T8-5 risk. This patient with abnormal infrared imaging, high index of suspicion. I do not initiate HRT, vaginal or systemic, share with breast specialist. This patient, referred by another physician, sought thermography because she refused to undergo mammography and was self-medicating with hormones. During the initial examination, we explained the difference between the tests, mammography and infrared vision. We recommended that she return to her gynecologist, discontinue hormone use, undergo a mammography, and come back within 3 months for a new infrared image assessment. However, she only returned after 4 years, now present with thermovascular risk level 5, unfortunately. And finally, I would like to present a significant clinical case. In this case, a 62-year-old patient with a BI-RAD 2 mammography has been monitored with infrared image for 5 years. She initiated HRT in 2019, but had to discontinue it after 1 month due to a significant increase in metabolism and corollary type vascularization in the left breast, raising the thermovascular risk to level 4. Can you see the middle image?
Yes.
Sorry. A few days after discontinuing HRT, the breasts returned to their previous state. Let's see the last image after discontinue HRT. There have been 2 or 3 attempts to administer both systemic or vaginal HRT, but the patient continues to show the same change. This is the same patient. She remains at thermovascular risk level 3, but has shown progression in the alterations of the left breast without hormone therapy. Over the past year, the average temperature of the left breast has increased by 37%. We are maintaining close surveillance because hair mammography, it is by RADS2 and ultrasound by RADS1, normal anatomical exams. This patient represents the majority of cases without traditional breast cancer risk factors, with normal mammography finds, where without infrared imaging, the metabolic and vascular alterations precede anatomical changes would not have been detected. These changes may increase the risk of breast cancer with the use of HRT. Conclusion: we need to carry out and publish more scientific studies that enable us to break down resistance to associating traditional breast cancer screening tests with the use of infrared imaging to monitor vascular and metabolic alterations that may indicate an increased risk of breast cancer and make early interventions. This way, we become more proactive in the management of menopause patients on hormone therapy, thus make treatment safer. Thank you so much.
Very nice presentation. Very good. We have a lot of questions, Rita. More than 100 questions. So, but let's see the best here. The people that one I would like to. We have 2 questions. One is about the hormones. And yesterday in Brazil, we have some kind of forbidden about hormone. Could you explain about this to us?
Oh, yes.
Thank you.
yesterday, the manipulated hormones were banned here in Brazil by Anvisa, equivalent to FDA in United States. It was also already banned in the United States by the FDA. The main issue is the patient safety, because the lack in the quality control over the manipulated hormonal medication. Additional, there is the instability of the hormone itself. When made through manipulation, it can undergo variations, and no one knows for sure what dose may be administered to the patient. So, for safety reasons, it was banned here in Brazil by Anvisa, just was already banned by the FDA in the United States. That's why it's important to follow official recommendations.
Very nice. There's a question, is simple. Don't worry, Rita, it's very simple. I'll help you. Because of the language, but I help on the language. Angelica Arellano, she's asking if a woman is being placed on hormone therapy in her 20s or 30s years old, should be begin doing thermography at that age so early before she starts the hormone therapy? Did you understand the question? Is here on the chat? It's here on the chat. Very young, if you recommend very young to do thermography before using hormone therapy.
Yes. Yes, because the density of her mama, we can show a better with infrared vision.
Yes.
And if the patient use hormones like contraceptive, we make infrared vision.
We could also answer with a question. Why not? Why not? If you have the possibility, why not? Okay, so if it's close, it's easy, it's there, it's possible, why not? And then the last question is very specific, Rita. I believe you have much more experience. Progestin, does progestin change the breast more or less than progesterone?
More. Progesterone,
Progestin.
Yes, but the studies show us that progestin with plus estrogen modify the breast, the very important changes in metabolic and vascular, and progesterone, natural progesterone, reduce the possibility that a bad action in the hormone on breast. Change, when possible, we change the progestin for progesterone, natural progesterone. The risk is lower.
Great.
Okay.
I'm very happy with the number of people participating. It's incredible. It is a sign that people are truly interested in learning more about infrared thermography. So I'm seeing questions here, and people send in my WhatsApp too. We want even more people to join in and share their experiences. There are many children, women, sick individuals who need our help. So we must think on them. Thermography and infrared imaging goes far beyond breast cancer. We are talking about healing medicine, surgeries, infection treatment, debilitating disease, diabetes, all of which can be managed and reduced with the use of infrared imaging.